And with that, we're going to start our debates. And so just a quick word of format, the way this is going to work. We have two cases, two locally advanced kidney cancers. I'll present the cases, and then we have three amazing panelists here, and I'll introduce them in a second. Each one will present kind of the data and/or the rationale when there isn't data for why we would consider surgery, radiation oncology, or medical oncology. And then we're going to open up to the floor, and we want to hear what you have to think. We want to hear what different perspectives are on how we should manage these patients. So with that, I'd like to introduce the panel. We have three amazing panelists in no particular order. First is Andres Correa. Andres is the Director of Research in the Department of Urology and Assistant Professor and the SUO Fellowship Director at Fox Chase. We have Shivani Sood, who's a radiation oncologist at UNC Chapel Hill and an assistant professor. And lastly, Sandy Srinivas, who is a medical oncologist at Stanford, where she is the clinical research group leader for the urologic program and been a principal investigator on a number of trials that you all know. So with that, we're going to start with the first case, which is an IVC thrombus. This may look familiar to some people in the room. 55-year-old man was walking around the Telluride Film Festival when he had lateralizing right flank pain. You can see his medical history there, surgical history mostly related to orthopedic injuries. At this point, was married with 4 children, had no grandkids. And you can see his labs, normal kidney function, pretty normal labs. And on CT and MRI, which I'm going to show you, is a 7-centimeter right renal mass and a tumor thrombus extending into the right atrium without evidence of metastatic disease. So here is the first CT scan, and we'll just let it roll through. I want you to take notice, this is not a quiz. Look how thick the cava is. Big, thick vena cava thrombus poking into the atrium, not with huge extension into the atrium. We'll let it roll back one more time. Here are your axial cuts. Once again, you'll see it just poking in to the right atrium. And for the surgeons, how thick it is, particularly at the hepatic vessels as it comes down the cava. On these cuts, we'll see the tumor. Not a terribly huge tumor in the right kidney, but obviously central and growing through the venous structures. And I'll show you just one more view. Here's your MRI, which gives a little bit of extra kind of enhancement. And I'm happy to answer any questions if people have them about the mass or imaging. I gave you just kind of the best cuts we had. So we'll pause, and with that, Andres is going to give us our first presentation.
Thank you very much. Thank you very much for the organizing committee for inviting me to speak. Thank you, Kevin, for the beautiful talk. It really puts everything into context of what we do. And thank you again for that wonderful story. So, I mean, this is a debate, but there is no debate. The standard of care for these cases is surgery. But we wanted to do is kind of in some way, kind of talk about how we can manage this multidisciplinarity to be able to give the patients the best outcome possible. So my job right now is to kind of put the case into context a little bit and see how surgery can be helpful and when we might need help from our medical and radiation oncologists to get these cases to go a little bit better and for patients to have better outcomes. So just to put things into context, so patients that have a mass or a kidney cancer is extending into the vena are considered stage 3. However, when you look at stages, these are not the right slides. Can we put the most updated slides in, please? We're good? Okay, let's try that again. We good? No, that's Sandy's talk. Yeah, you don't want me speaking about this. Okay. So just to keep things moving, I know that we're sharp in time, and so we want to really have the Q&A to be the main portion of this case. So just talking about cases that are going to the caval thromb into the cava, those are all categorized as stage 3 disease. However, the group at Mayo has really divided this into levels. And it's important because when it comes from surgery, the level really dictates the complexity of the case. So you have level 1, which is the thrombus just kind of in the vein itself. Then you have level 0, just in the vein. Level 1, just a little bit into the cava. Level 2 is a thrombus that goes up into the level of the hepatics. Then level 3, which is above the hepatics. And then level 4, which was what Kevin had, when it's going above the diaphragm into the atrium. So again, I have no financial disclosures around this talk. And so when you look about this, you really have to look about it in the level sense and not in the stage sense, because really the morbidity and potential mortality for the patient intraoperatively does increase with the complexity of the case. And also it matters about how patients are going to do prognostically. So the higher the level of the case, the more likely they are to have a cancer-related death or a cancer-related recurrence. So when you look at these cases, and I'm going to quote one of my partners and my mentor, Alex Kudakov, is that when you see these patients, decisions are more important than incisions. And so at this point, when you have these patients in clinic, you really have to weigh what are the oncological factors and what are the surgical complexities of the case and the medical issues the patient might have that will lead you to get the patient safely through a very complex operation. So when we talk about tumor factors, the really important thing here is the patient has metastatic disease or not. And this is work that has been done by the group at MD Anderson under Jose Coram, that they really looked at what are the prognostic factors that really drive survival in these patients. And the most important things that you can have is either the presence of nodal metastasis or metastatic disease. And as we can see from the Kaplan-Meier curves, if you have one or both of these factors, your survival really, really decreases. So this is an opportunity to maybe get your medical oncology colleagues to maybe consider early systemic therapy, because again, we want these patients to have the optimal oncological management, and surgery might not help them. So what about histology? So this is, again, work that's being done both at MD Anderson and the Mayo Clinic, and it's work that has shown that actually patients that have a non-clear cell histology do poorly. This is most likely related to the fact that we really don't have, until recently, very good systemic options for these patients. But now with the new trials coming up and the better response rates, that may change. But it's something to be able to understand that if you don't have a clear cell histology, the patient might not respond very well to systemic therapy. And maybe it's a patient that you want to take to surgery earlier on. So what about patient factors? So as we know, when patients present with caval involvement, they just don't present with a renal mass. They can have compromise of other organs, especially the liver. So these patients can develop Budd-Chiari formation. That can be acute, that can be chronic, but that really can affect the patient's ability to survive the surgery. So it's very important for us to have a good assessment of how the patient's liver function is before the surgery. And then, of course, the vascular complications. Is the patient having any cardiac compromise related to the thrombus itself, or any kind of venous congestion or severe venous occlusion, and how are you going to prepare for the case? Are you going to resect the cava completely like happened in the case of Kevin, or are you going to just remove the thrombus by itself? So again, this is something that is in the back of our minds. Another thing is that, as I said, the patient's ability to survive the surgery is completely related by how they present to you. And so taking everybody that has this caval thrombus to surgery might not be the best idea, because these patients can have a mortality during the procedure, and they're probably better served by either having systemic therapy or the disease to be downstage with some radiation therapy. And hopefully we'll hear some about that with the other talks. So how can we predict if these patients might benefit from systemic therapy, radiation therapy? And this is work that has been done by the Mayo Group when Sarah Sutka was there. And they looked at imaging, and they found these prognostic factors that potentially can help us. And as Phil demonstrated on the MRI, how wide is the cava at the level of the renal vein? Is there complete occlusion of the cava? And what Dr. Sutka showed there is that if you have 3 of these factors, the chances you're going to have vascular compromise, you're going to need a cable replacement or a cable resection, is a lot higher. And if you add to that MRI findings such as thinning of the vein or irregular vein findings, actually the predictive ability you're going to need a vascular compromise increases. So this is something that potentially you can use in the preoperative setting to be able to optimize the patient outcome by either giving the patient some radiation therapy or systemic therapy before the operation. So the most important when it comes to this, and I know Kevin probably went through this when he talked about having all the team members that he saw, is the fact that this is not a single surgeon operation. You really, really have to have a team, and that's involving the hepatobiliary surgeons and the cardiothoracic surgeons to be able to get the patient safely through that operation. And this has been shown. So we've shown that if you have teams that work together and are used to doing this in an expert fashion, in more numerous cases, people do better. And you can see, and the decrease in mortality is quite significant when people work together. So again, this is a collaboration. These cases should be done in Center of Excellence. The people do a lot. And it should not be a hawk. It should be the same team doing these cases over and over so we can potentially give the patient the best outcome possible. So just putting the patient into context, just to summarize the venue. So if you have a patient with a level of thrombothrombus, does the patient have metastatic disease? If they do, that patient should probably get systemic therapy before they go to resection. If the patient is sick, does the patient have a bad performance status? Do they have evident or liver dysfunction? Maybe that patient should be medically optimized before they go to resection. Is the patient surgical resectable? Can we optimize the surgical resectability of the patient, yes or no? And if so, we should probably want to do that before we take the patient's surgery. If everything is lining up perfectly and the patient can have a safe operation, let's go ahead and move to surgery. With that, I conclude, and eager to hear what my other panelists say.
Dr. Srinivas?
Good morning. Thank you again for this opportunity. And thank you, Andres. I thought there would be some differing numbers. I think I'm glad to hear that the data that you've shown is going to be very similar to what I'm going to be talking about. So here are the learning objectives. And here is why I think systemic therapy should be offered to these patients. The relapse rate with level 4 thrombus, as Andres showed, is really high. I'm going to show you that the mortality from surgery is not trivial. I think we have some history that we have learned lessons from Carmina and from Sirtime. But really, I think the real reason why there should be a change is because systemic therapy for metastasis is truly a success. We have incredible high response rate, both systemically and locally within the kidney as well. And the real reason why I think it's safe to offer systemic therapy is that the lack of progression is really low, that it's unlikely that by offering patients systemic therapy, we may lose this window of opportunity for surgery. So you saw the different levels of thrombus from Andres' talk, but here are some of the numbers. These differ with different decades of literature, but overall, I think with surgery, the overall survival, 5-year overall survival is just 35%. We do far better with systemic therapy today with the 5-year overall survival. The risk of local recurrence with surgery alone is 15%. And again, tumor progression is about close to 50% for patients who undergo surgery alone. And not everybody has access. I mean, Kevin's story was incredible. I don't think everybody across the country and even across the world have access to such high quality surgery. So this is what is up in the literature, that the complication rates are around 50%, perioperative mortality of about 10%. You can have a median blood loss of almost 2 liters, and patients have hospital stays of around 11 days. And even at high volume centers, the 30-day mortality ranges from 1 to 10%. So everybody in the room is familiar with the story about Carmina. True, Carmina was in the era of TKI, and Carmina was for patients with metastatic stage 4 disease. But I don't think that's that different from patients with level 4 thrombus, where your risk of metastasis is about 50%. This is really micrometastatic disease. So should we have another Carmina trial done for this group of patients, where clearly systemic therapy outperformed doing upfront nephrectomy? And I think Sirtime, while it wasn't a powered study, Sirtime also showed us that patients who had deferred nephrectomy following systemic therapy had almost a doubling in overall survival compared to those patients who had upfront nephrectomy. So I'm just going to show in the next several slides, not level 1 evidence. Unfortunately, we don't have great trial data to support systemic therapy, and that's where I hope that as a field, we move forward to having trials in this space. But here is a phase 2 trial looking at single agent axitinib. Patients were given axitinib for 8 weeks and were then taken to a nephrectomy. Overall, about 35% of patients had a reduction in the Mayo level thrombus. A third of patients had a thrombus in the vena cava and 25% in the renal vein. But ultimately, almost half of the patients had a less invasive surgery than what was planned. How about our contemporary treatment today is not single agent TKI, it's really IO TKI or dual IO therapy. Again, we don't have a lot of data to support, but here is a case series looking at patients who had IO TKI for IVC thrombus, and you can see the decrease in the, both in the primary as well as in the thrombus itself. 3 of these patients had a decrease in their thrombus levels. They note that surgical margins were negative, and none of these patients experienced any intraoperative complications. So this is our success, right? This is what we now know with systemic therapy. We have 4 different options, but I'd like to highlight really here the response rate that we have in the metastatic setting. It ranges anywhere from 40% to up to 70% when we use IO-TKI, let's say with Len-Pem or even with Cabo-Nivo. Most important is the lack of progressive disease. So if you look at primary progressive disease, it's really single-digit numbers. So 6% in the Checkmate 9er with Cabo-Nivo and 5% with Len-Pem. So this is very reassuring that by giving patients systemic therapy, we are unlikely to have progression, and these patients could be managed safely with systemic therapy. We do have some retrospective data. This is a nice paper looking at patients' response in the primary. So the top half is looking at Ipi-Nivo, and the second half looks at the IO-TKI data. And this looks at what is the response in the kidney itself in pink, and in blue, what's the response overall for metastatic disease. And you can see overall that the response in the primary ranges anywhere from 10 to close to 50% of patients. And the data on the right looks at patients who went on to having surgery. I think impressive data here to look at the small patients in pink. These patients at nephrectomy had a pathologic complete response. So finally, the least level of evidence is our own anecdotal experience. So this is a patient of mine who had metastatic disease. He was initially treated with sunitinib back in the day, and I think he was diagnosed in 2015, went on to staying on sunitinib for a couple of years, and then had progression and went on single-agent nivolumab. He was on nivolumab for about a year and had complete response in his lung, and eventually was taken to a deferred nephrectomy, and at pathology, he had completely no evidence of active disease. A second patient of mine, again, where I truly believe that size is not a perfect way for us to evaluate response. So this patient presented with a large renal mass. Ultimately, he had both nodal as well as lung metastasis. He went on Ipi-Nivo and went on maintenance nivolumab. And after a year of therapy, he had a pretty impressive response in his lung and lymph nodes. And his renal tumor also shrank, and he was taken to a nephrectomy and had less than 1 centimeter viable disease in his kidney. So clearly, I think giving patients systemic therapy, you are seeing a pretty good response in the kidney. And what can we learn from our colleagues from other cancers? This was a paper from JAMA in 2021, looking at the trend of neoadjuvant therapy in a variety of cancers. And you can see up, this is in breast, ovarian cancer, many GI malignancies like esophagus, and even pancreas. Pancreas, the trend for giving neoadjuvant therapy is almost up in many, many cancers. And FOLFIRINOX that is given in pancreatic cancer has a response rate of 30%. You know, with such high responses in RCC, systemic therapy, an argument to give systemic therapy is quite clear. So what are some unknown questions? Clearly, we need level 1 evidence to support the use of systemic therapy. I think we don't know what the timing of nephrectomy should be and how long should the duration of therapy be for systemic disease. Post-resection, what is the role of adjuvant therapy? With the pembrolizumab data now showing survival, is that a viable option? And I'm really looking forward to hearing from Dr. Sood about radiation as an option post-systemic therapy. Fortunately, there are some ongoing clinical trials looking at LEN-PEM, neoadjuvant SABRE, and AXI-AVI, but these are also single-arm trials, but that's at least a start for us. So I'll conclude by saying I agree with Andres that I think this should be a multidisciplinary approach. We need to do what is best for the patient. Systemic therapy has a very high chance of response. And I think the endpoints, while we await larger trials, altering outcomes such as a lesser morbidity of surgery should be our goal. I think I'll stop with that.
And last but not least, Dr. Sood.
All right, well, thank you so much for the opportunity to be here and to join an esteemed panel as we talk about how we can do a better job to work together to take care of our patients. So I'll be arguing the pro-radiation scenario here for our patient who presented generally healthy, but while at the Telluride Film Festival, coming in with a large renal mass and a high-level tumor thrombus in the absence of known metastatic disease. So this is a very important question given the prevalence of IVC invasion. We know that up to 10 to 25% of new renal cancer cases have IVC invasion, and that this is associated with high morbidity and mortality, whether via venous congestion, Budd-Chiari syndrome, pulmonary embolism, or other mechanisms. As discussed, the primary treatment is surgical resection, but we have limitations, namely high perioperative morbidity, up to 34%, high perioperative mortality, up to 10%, and a high risk of relapse and metastases post-resection. So specifically for patients who have a greater than level 3, as highlighted in the schematic to the right, IVC thrombus, we can see 5-year cancer-specific survival of about 50% and overall survival lower, around 40%. And so this is an area where we ask the question of whether radiation as a preoperative therapy may decrease the risk of local recurrence and the dislodging of live tumor emboli that can give rise to metastatic disease. So I want to start with a little bit of historical context because historically, kidney cancer was considered radioresistant based on in vitro data and results from clinical trials that were done in the 1970s, 1980s, where we really failed to show that we could provide a benefit with neoadjuvant or adjuvant regimens. And so part of the reason why I actually get to be part of this debate is because we've had a lot of recent technological advances, namely the advent of stereotactic body radiation therapy, also known as stereotactic ablative radiation therapy, so SBRT or SABRE. And with these techniques, we are able to get high dose into the tumor, but with a steep fall off in dose so that we're able to spare healthy, normal tissue. And the experience to date with SBRT for RCC and other kidney cancers has been very promising with regards to high rates of local control. So now we have the privilege of better understanding the biological underpinnings of that efficacy and potential routes for synergy with other therapies, such as systemic therapy, as well as surgery. So shown here to illustrate this, on the left, we have a schema that illustrates the cell-killing mechanisms of SBRT. We have direct killing of tumor cells, and then we also have indirect killing via vascular damage. We also know that SBRT stimulates an anti-tumor response, leading to suppression of recurrence and metastases. Another area where we've started to really develop a better understanding of how SBRT fits into the biology of RCC is that, for example, in many RCC, there is a VHL mutation. This simulates hypoxic conditions where radiation does not perform as well at conventional doses, but at higher levels, we are able to overcome a lot of these limitations. All right, so given that the data that is specific to tumor thrombus itself is more narrow, I want to start by recapping the data of SBRT for local control. So shown here is data from the International Radiosurgery Oncology Consortium for Kidney. And I will just say that this is a group that has spearheaded a lot of advances in this space. So shown here is the individual patient data meta-analysis for patients who were undergoing SABR for primary renal cell carcinoma. We can see here that the SABR was delivered as either single or multiple fractions of greater than 5 gray. This data was quite mature, and the median follow-up was 5 years. And the local failure at 5 years was only 5.5%. There were no grade 3 toxic events. There was one patient who had a grade 4 toxicity, and there were no treatment-related deaths. So this mature data lends support for renal SABR as an efficacious modality for local control in renal cell carcinoma. Okay, so now, in terms of more specifically tumor thrombus, the number of patients for who we have data is limited, but again, it is promising. So here, for example, is a retrospective study of patients who were treated with radiation. 50% of patients had a level 2 to 4 IVC thrombus, so representative of the scenario we're discussing here. 67% of patients had metastatic disease, and 2/3 of these patients were suboptimal candidates for surgery. All of the patients received SABR. Median overall survival was 34 months. And notably, there was a radiographic response in about 60% of patients. And for the patients who underwent SABR for symptom palliation, they all reported some degree of palliation of symptoms. And adverse events were limited primarily to grade 1, grade 2. So this underscores for us that SABR for IVC thrombus is safe and feasible, and SABR may be considered as part of a multimodal treatment approach for patients who have an IVC thrombus. Shown here next is data that was primarily spearheaded by the group at UT Southwestern. So this was a phase 2 trial with a safety lead-in for patients who have Mayo greater than level 1 tumor thrombus. Patients received upfront radiation, and then they went to an open nephrectomy and thrombectomy. In terms of the primary safety endpoints, there were no grade 4 or 5 adverse events within 90 days. There were lower grade adverse events, and all patients were alive at the time of median follow-up at 24 months. Of note, one patient had de novo metastatic disease, but for the 3 patients who actually had metastatic disease when they presented, one had a partial response of metastases and one had a complete response without systemic therapy. So again, this highlights that the approach is feasible and well tolerated, and the phase 2 results from that study are very much eagerly awaited. To highlight some of the other work that is in process in another eagerly awaited trial, this is an ongoing prospective single-arm cohort trial that is being run out of Beijing. You can see here a schematic outline of their treatment plan, where patients with renal cell carcinoma with Mayo level 2 to 4 tumor thrombus will finish radiation therapy to the thrombus area and then subsequently undergo radical nephrectomy and thrombectomy. And then the main follow-up endpoints will be an assessment of safety as well as disease-specific outcomes. So in conclusion, high-grade IVC tumor thrombus, as I believe we have all highlighted here, is associated with substantial morbidity and mortality. SBRT is a non-invasive preoperative therapy option. The data is admittedly limited, but it shows the technique is well tolerated. We know based off of preliminary data as well as proof of principle that SBRT decreases the tumor thrombus extent and can make lesions more amenable to resection. SBRT is also likely to decrease the probability of live tumor embolus. And so the prospective phase 2 data are eagerly awaited, and I think there are many opportunities with the current data for us to collaborate on patient care and to think about innovative trials such as those that were proposed where we can really optimize outcomes for our patients. So thank you again for the opportunity to be part of this debate.
All right, amazing group. So I'm going to first ask from the audience, if anybody has any questions, comments, feel free to come up to the microphones. Otherwise, I will ask questions. We're going to take a little bit of time here to kind of run through it before we get on to the second case. But I just want to make the comment, Kevin, when you were diagnosed in 2015, this would have been a really boring debate. There was not much to talk about. And in 8 years, all of the changes that have happened in kidney cancer, both with systemic therapy, now with radiation coming on board, this is a much more interesting topic for this audience and for patients. Brad.
Thank you very much for those great presentations, and Kevin, thank you for sharing your story. I just want to make sure we don't get the messaging wrong here. So I think Andreas hit the nail on the head with his opening comment. The standard of care in the setting of a non-metastatic patient with a tumor thrombus is surgery. So to just reiterate, these are not necessarily patients with micrometastatic disease. In fact, for patients that are node negative without metastatic disease that's evident at the time of surgery, 50 to 60% will be cured durably with surgery. Now, I don't think we have any data from anybody with any length of time other than surgical that would come close to that. So we can't forget that. In addition, as a few of the speakers pointed out, it can be morbid surgery, but it's not morbid surgery if it's done with an experienced team. So the mortality rate should be under 3% for a surgery like Kevin's done by an experienced team. So we have to work on providing access to those surgical teams to the people that don't have it to get potentially curative approaches. I'm 100% aligned that we need clinical trials in this space, but I don't know that we can extrapolate from a bunch of diseases where neoadjuvant therapy was proven to be better when those are diseases that respond to cytotoxic chemotherapy, and we have a biologically very different disease here. So I'm optimistic and hopeful that my surgeries will be facilitated by things like neoadjuvant therapy, whether that's radiotherapy or systemic therapy. But I just want to also remind people that that doesn't necessarily make the surgery better. So yes, we've all seen cases of pathological CRs, but we've also done many resections and reconstructions of vena cavas where perhaps if we had started off with surgery, the thrombus would have slid right out and the patient would have had a simple cavorrhaphy with a couple prolines and you're done. And then you don't wind up with a caval resection or a caval replacement, which can happen if you've given some of these neoadjuvant therapies. So long-winded, I apologize, but I just want to make sure that for the audience, we are all in agreement that in the absence of metastatic disease in the surgically optimal patient, surgery is the optimal therapy until proven otherwise. And that's all I want to say. Thanks.
Dr. Steller? Oh, over there first. Go ahead.
Yes. I don't know if you know this paper coming a little, I think it's a couple of months ago in Nature Review, showing that the grading of the IVC tumor seems to be the most predictive factor by the recurrence. And I comparing to the grading of the primary tumor. So I'd like to know what you think about that. I know that there is no pathologist on the stage, but I would like to know what you're thinking about. And do you think it's interesting to do it usually?
Sure. Andres, or anybody want to?
Sure. So if I understood your question, Oh, this sounds really weird. If I understand your question, is there a subgrading we can do on levels to actually predict better prognostic factors? I think that the levels are helpful. I think that they provide some information. I mean, to some of what Dr. Leibovich was saying, I think that the work that needs to be done is actually how to better characterize the thrombus radiologically. So no all thrombus are created equal. We have those ones that actually are a solid thrombus that slide out very easily. And there's ones that's kind of this lodge of tumor that kind of come out of the cava. I think that those probably respond less to systemic therapy than the solid ones. And sometimes I think radiomics might be help us identify those people that might better predict. And to talk to Brad, I mean, I didn't want to make, my opening statement was to make this more collaborative, but the reality is that we also have a window of treatment, and if the patient does progress from that window because of systemic therapy, they might come off of the resection window. And so, yes, radiation and systemic therapy are helpful, but we also have to keep in back of our minds that we're dealing with a tight window to get that patient safely through an operation. So, again, I think that we're going to need better imaging to characterize these patients, and hopefully some molecular imaging will come into play that will help us. And I think that the radiomics with the thrombus is really going to put a cue to who can actually benefit from systemic therapy, because right now it's a little bit of a wild guess, besides knowing the histology of the patient.
Dr. Taylor, we'll take one more comment, then we've got another case.
It's really short.
Yeah.
I want to bring back to the patient. I think he's missing up there. Kevin, after having seen all those data, would you do surgery again?
I would. When I was diagnosed, I just relied on who I felt was the best in making those decisions, and one of the things that I cherished was that I didn't have to second guess anything. And so it was a long recovery and very difficult, but I'm alive and I'm very thankful, and I would.
Thank you. I think that concludes the discussion on that.
Perfect. Thank you, Michael. Good. So I'll just summarize. It's a really interesting conversation now, and Brad brings up there's oncologic outcomes, there's palliative indications for both our surgical therapies and our systemic therapies, and melding these together and figuring out what's optimal for our patients is really the key. So with that, we're going to come up with another complex case and another complex patient. So this is a T1B renal mass in a solitary kidney. So this is a 75-year-old man who shows up in a urology clinic, referred in with a 6-centimeter complex renal mass, already biopsy proven to be a clear cell renal cell carcinoma. He has a left kidney, but it's basically non-functional from unknown etiology, maybe congenital, maybe related to his really significant BPH, which requires CIC, or clean intermittent catheterization. So here's kind of the imaging history and story. Initially diagnosed with a large mass. He had a biopsy with an outside physician, showed to be renal cell. Basically, this hasn't grown, or has grown very slowly over the course of the next year to year and a half. But it is now starting to approach a 7-centimeter cutoff, when a lot of us know the risks of high-grade cancer and metastatic rates start increasing significantly. Here is imaging. Coronal cuts. And there you see a large lower pole renal mass. We'll let it roll through one more time. Kind of abutting the collecting system, away from the hilum. And I would just say not an easy partial, but partialable. I will also mention, I may forget to put the labs there, his GFR is not great. His wife has recently died. He is interested in being active and does not want to be on dialysis. That is his #1 priority, very explicitly stated in clinic. So with that, we're going to start with Andres again, and then we'll change the order of our other panels.
Thanks again. Again, within the last case, the standard of care for this patient is surgery, and surgery alone at this age. I'll make that clear. However, we do have evolving therapies that can help take care of this patient in maybe a safer fashion. So just setting the case for surgery here, again, I have no financial disclosures with this talk. And again, the question is not to resect or not to resect. I mean, I think that the details are the important thing, and how the patient comes to you is what really matters. And so again, less than the last talk, you have to look at what are the tumor factors, or what the patient cancer telling you that you can potentially say, would a resection be safe and provide them a long oncological outcome? And what are the patient's medical issues? What are the patient's current and maybe future renal function? And what is the complexity or the possibly morbidity of that operation you're doing? And this is what we're weighing in clinic to make the best decision for the patient. So what are the tumor factors? And the reality is that the current imaging modalities that we have right now are kind of limited to give us any kind of really prognostic information. And the reason for that is because even when we see little nodes on the patient, 50 to 40% of those are negative when we do a lymph node dissection. So to be honest, just saying that someone has some mildly elevated lymphadenopathy in a scan doesn't mean the patient has no positive disease. And really, we're truly, truly limited at looking at micrometastatic disease compared to like prostate cancer. We have like PSMA PET imaging. So it's molecular imaging dissolution here. And I think that we have a signal. I mean, we have dirotuximab, which is an agent that's been available for quite some time. The first clinical trial was published in 2012 by Dr. Russo, and the molecule sadly didn't come because it didn't clear FDA. But now with the SERCON trial, I think there is hope that it will be FDA approved, and something that initially is going to be approved for the small renal mass setting, but potentially we can use in the locally advanced cancers or these more complicated cases. And as the picture shows, this is patient that with PET-avid imaging, it doesn't show any avidity of those lymph nodes, but when you look at dirotuximab molecular imaging, you can definitely see that patient has nodal disease. And that patient is a patient you probably want to give systemic therapy up front instead of putting them at risk of potentially going to dialysis from resecting a localized tumor. So how to also talk about, can we predict if someone is going to have a stage 3 versus stage 1 kidney cancer? And the reality is it's quite hard given the current information that we have, but we do know that patients that have stage 3 disease do worse than patients that have stage 1 disease. And our ability to be able to tell these patients, we're going to cure you, we're going to put you through a risky operation, our job to some degree is being able to tell the patient up front, what is the likely chance that we're going to give you a cure for that resection, and that is to be able to accurately predict if they're going to have a stage 3. So the best things that we have right now, to be honest, is imaging related, and that's size of the mass and the complexity of the tumor. And this is through a meta-analysis that was done by the Italian group, looking at all the information that has been available to be able to predict upstaging from T1 to stage 3. And the best information that we have is that the bigger the tumor, the higher likely the patient will be stage 3 disease, and how complex the mass is also provides some information. The Cleveland Clinic group actually just recently published this model, which is actually how smooth the border is. And I think that actually has some validity. I think that if you have a mass that is uniform or has a mass that really doesn't have that nice pseudocapsule you see on the CT scan, that's a patient that likely has a high-grade tumor that most likely will be upstaged at the time of partial nephrectomy. What about histological determination? So important thing here is that not all big renal masses or large renal masses are actually cancerous. And I think that before we put a patient through a solitary kidney partial nephrectomy, as they did in this case, we need to do a biopsy to make sure the patient doesn't have a benign or an indolent pathology. And as we know from this paper that was led by Alex in collaboration with the group at Penn State and the University of Chicago, is that having indolent pathology, either benign or having a chromophore oncocytotic tumor, actually is not that uncommon in patients that have large renal masses. So also, what other factors we can potentially gather from a biopsy that can help us see if this patient is going to have a chance of having an early recurrence? And by an early recurrence, meaning that a recurrence within 2 years, where you say, well, if the patient recurs within 2 years, am I really truly helping him by resecting this tumor? And this is work that we did in collaboration with the ASSURE trial, and is looking at what are the really risk factors that drives that early disease progression. That's part of the ASSURE nomogram. So we know that coagulative necrosis and sarcomatoid differentiation are key factors. And if you plug those numbers into patients' risk of having early recurrence, if you don't have those factors, the chances of having early recurrence is only 8.0%. However, that can increase up to 30% if you do. But some argue, how are you going to find that on a biopsy? And the reality is that you can. It depends on how you do the biopsy. So this is work done by Jason Abel at the University of Wisconsin. Is looking at the quad biopsies, and it's looking at if you biopsy the kidney in multiple zones instead of just in one zone, you might be able to get a better assessment of what the histological information that patient has. And that's because tumors are heterogeneous, and we know that. So you might miss the sarcomatoid component. You might miss that necrosis component by just doing a single biopsy. And be able to have that information up front might be helpful. Also, they showed that actually there wasn't an increased risk of bleeding associated with doing the quadrant biopsies compared to just the standard biopsy setting. So this is something that we have adopted at Fox Chase, in which in patients that we're really thinking about doing these complex partials, we really want to see what the oncological potential of that mass is before we go to resection. So now let's talk about the surgical and patient factors a little bit more. So when you look at this, and it's hard for me not to talk about competing risks coming from Fox Chase, but you have to look at the patient. And is the patient really going to benefit from having that mass removed? And the reality is that we know a lot of patients can be watched safely on the active surveillance that are highly comorbid and unlikely to live for a long period of life. However, this is not the case for this patient. I mean, this patient's likelihood of passing away at 5 years is 13%, and the likelihood of passing away from kidney cancer is not trivial, it's 9%. And when we put this into the prognosis model with the Lee index, the patient's expected survival is 12 to 13 years. So I think that this patient, at least at this point, doesn't meet the criteria that we're just going to put them on a kind of active surveillance or watchful waiting approach. So what about mass complexity? How complex it can is? And I'll give an homage to Alex and Rob. Alex is our Novick awardee this year, but they were kind of the first that actually start talking about mass complexity and that not all masses are created the same and how that complexity can, to some degree, impact the outcome of our patient. So if we look at the patient presented here, the patient has a high complexity mass, and this has been associated with increased overall major complications, urolink ischemia, time, and conversion to radical nephrectomy. When we put this into the model, the patient's risk of complication is not trivial, it's about 22%. Now, something that the patient has going on for is the fact that he has a very big renal pelvis, and that's probably related to his BPH and chronic obstruction. But what Rob showed in a paper he had is the fact that if you have this extra renal pelvises, the chances you having a urine leak is actually lower. So this patient actually has something going on for himself instead of just having a little bit of mass. So the chances of urine leak is actually not as high as we will think it will be. So what are the renal function assessment? And this is really the conversation that we need to have is what is the chances this patient might need either short-term dialysis or long-term dialysis following this resection. And there's some of these factors are modifiable, but some are not. So and the most important one that has been shown is actually how the patient's kidney function is at the moment. And we know that from work that is being done in collaboration with Fox Chase, the Mayo Clinic, and Cleveland Clinic, is that the biggest predictor of you needing or having significant stage renal disease is what GFR you came in at the time of surgery. And it's not only if your GFR is decreased, but also if you have any evidence of protein in your urine. If you have microalbuminuria, that clamping time is going to lead you to have an increased risk of having early dialysis than a patient that doesn't. So this is not something we can modify. This is that the patient comes to you, this is likely to get worse over time and not to get better. The clamp time we can definitely do. And so the early data from the Cleveland Clinic was the fact that any clamp time, warm ischemia time greater than 20 minutes, that actually was reassessed and was found to be 25 minutes, or any cold ischemia time was greater than 35 minutes was associated with an increased risk of worse kidney function, both in the acute setting and the long-term setting. So can we minimize this? And the reality is yes. I mean, I think that some of my colleagues are going to speak about it. We can shrink these masses so the ischemia time can be decreased. So this is potentially modifiable. We can, and the other one is the amount of parenchyma spared. In this case, not as much because the patient actually has the entire upper and mid-pole available as renal function, but there's cases in which the mass is occupying the central part of the kidney, and the amount of parenchyma spared is actually quite limited. And by being able to shrink the mass, we'll be able to increase that patient. So that's potentially modifiable. So these are the things that we're thinking about clinic about how to help this patient. And this is truly important because we know that patients that go into dialysis after surgery, they really don't do well. And I will argue that looking at this data that actually, if this patient gets put on dialysis after a surgery, his overall mortality is probably higher than somebody that actually gets just this mass watched. I mean, the new data has shown that people that go into dialysis when they're early, above the age of 75, is quite high at that 12 months. So I'm not trying to say that surgery is not the standard of care for these patients. I'm not saying that at all. But as surgeons, we also have to be cognizant that what we do does have repercussions, that we need to assess the patients and make sure that we're not giving the patient an increased risk of mortality by potentially putting them on dialysis. So again, just putting things into context so my colleagues can go ahead and criticize surgery, is the fact that if the patient has no positive disease, or they potentially have stage 3 disease or bad factors on histology, they probably should have an oncological evaluation that probably can potentially optimize. What is the clinical status of the patient? The patient is highly comorbid and unlikely to live the next 5 to 10 years. Maybe that's a patient that should have non-surgical management, either with radiation therapy or active surveillance. What is the risk of the patient having significant GFR loss? And if that's significant, then maybe we can do surgical optimization by giving the patient some preoperative therapy beforehand. But again, if the patient doesn't meet any of this exclusion criteria, the standard of care is surgery, and this patient should be dealt with surgery. However, with cranial advances, we know that this patient can be better served by having multimodal management. Thank you.
Thanks, Andres. And this time we're going to bring up Dr. Sood first.
All right, well, thank you again for the opportunity to participate. I'll be presenting on the potential role of radiation therapy for this patient. So again, this is a patient who per presentation is generally healthy, but with a solitary functioning kidney, and now a T1B bordering on T2 RCC in the functioning kidney. So first, this patient is 75, and that's notable as kidney cancer incidence is increasing, and that increase is the greatest amongst patients who are greater than 70 years old. We know that elderly patients, even with a T1 RCC, have a greater risk of cancer-specific mortality compared to their younger counterparts. Our outcomes are optimal in early stages of disease, as we all know, and is highlighted in the figure to the right, but comorbidities and performance status, as we learned, may preclude invasive interventions such as surgery, radiofrequency ablation, cryotherapy, embolization. So treatment really must balance preventing progression versus causing toxicity, adverse events, a detriment to the quality of life, and negative impact on renal function. In terms of the overall management paradigm, as we nicely went through in the first presentation, we favor nephron-sparing therapy to limit a decline in renal function. Invasive treatments do require that a patient is healthy enough for anesthesia, and while a partial nephrectomy might be preferred in this scenario, there may be challenges, especially for central locations as well as large tumors. We also know that complications in the setting of a solitary kidney are not trivial. The median perioperative GFR decline with surgery is somewhere on the order of about 10 mils per minute squared. And with at least 20% of normal parenchyma spared, still about 8% of patients may require dialysis. Cryotherapy, radiofrequency ablation, those are alternatives, but they are typically limited to smaller lesions. And so this opens up a scenario where we may have a role for SBRT. And so these scenarios and the kind of pros and cons are listed here in this table. So again, I'll just acknowledge that radiation is kind of the new kid on the block in terms of talking about renal cell carcinoma, largely due to our advances in technology and the high dose per fraction. And I will say, when we initially had this technology, we probably spent our initial efforts convincing ourselves that it works and convincing ourselves that there was a biological reason why higher dose per fraction would make a difference. And now we have robust data that we're able to present to our colleagues and importantly to our patients as we think about multimodality approaches to their treatment. So again, credit to the International Radiosurgery Oncology Consortium for Kidney for really pioneering a lot of this important work. So the data I'm showing here are individual patient data sets from 9 of the IROC kidney institutions. We had patients who received single or multi-fraction SBRT, and there was very good local control when they had their short-term follow-up. Adverse events were relatively limited, especially when we look at high-grade toxicity. Notably, these data have matured really well. So we recently got data with the 5-year outcomes from the IROC consortium, and we can see local failure at 5 years, 5.5%, no grade 3 toxic events, 1 patient with grade 4 toxicity, no treatment-related deaths. And if we try to find, kind of comparable numbers for a nephrectomy scenario here using the Sloan Kettering nomogram, conventional histology incidentally identified, assuming the staging is the same at time of resection, we might see a 5-year recurrence-free probability around 89%. So really, with SBRT, we are seeing similar control rates to what we might achieve surgically. Now, the next question is, if we're looking at, SABR or SBRT in a solitary kidney, do we actually get the same oncologic outcomes? And again, credit to the IROC Consortium for actually doing a subgroup analysis of patients who have a solitary versus bilateral kidney. And as you can see here, based on the various kind of data points or evidence of control, that we actually do get strong control, and there's no difference in oncologic outcomes between patients with a solitary versus bilateral kidney. I will acknowledge that this data set did have a median tumor diameter of about 3.7 centimeters, so a little bit smaller than the patient who we are considering here. But about 40% of patients had a tumor larger than 4 centimeters. So I think it is reasonable to interpret this data in the context of the scenario that we are considering. The next question is, what is the impact on renal function? Because we know this patient said they definitely do not want to go on to dialysis, and this is one of our big considerations, is how do we protect quality of life and take into account all of the patient-specific factors that play a role in our recommendation. So here, this is actually very exciting data that just came out last month at ASTRO. So again, the IROC Consortium looking at patients with a solitary versus bilateral kidney. The GFR change at 5 years for a solitary kidney, around 14.5 versus bilateral kidney, 13.3. We can see here in terms of rates of end-stage renal disease, 7.1% versus 6.7%, and importantly for this patient, a very tangible endpoint, whether or not the patient is going on dialysis, 3.6% versus 3.7% for solitary versus bilateral kidneys. So this is really very encouraging data that kind of fulfills that promise of the idea that you can target your dose, you can get high dose into tumor, and help spare normal tissue and functionality with an acceptable outcome. Most of the data I've given you thus far has been from the IROC team, but we also now, again, fresh this last month at ASTRO, have data from TROG with Fast Track 2, so focal ablative stereotactic radiotherapy for cancers of the kidney. This was a multi-center phase 2 trial for non-operable patients where we were comparing, or they were comparing, again, focal ablative therapy and looking at the outcomes in terms of control. So local control of 100%, freedom from distant failure 99%, cancer-specific survival 100%, renal function loss, again comparable to the IROC data with acceptable toxicity. What is underscored though by this study is that for an operable population, we still need prospective randomized data, and that is very much an area where we are missing. So one of the questions is there support for a randomized study? One of the questions we ask is there equipoise? Is there equipoise amongst the providers? Is there equipoise amongst the patients? Are these studies doable? And so the data from RADSTER, which compared SBRT versus RFA for small renal masses, was a pilot feasibility randomized control trial for patients with masses that were less than 4 centimeters. They received single fraction treatment, overall, acceptable outcomes. But the most important endpoint was that they showed a trial of SBRT versus RFA was feasible. And so RADSTER 2 now will be a non-inferiority trial of SBRT versus RFA or cryoablation. And so I would say that a prospective trial of surgery versus SBRT is indicated for operable patients, and that based on the data that we have from RADSTER, it should be feasible if done thoughtfully and in a way that integrates with, what providers are comfortable with and where patients feel comfortable in a scenario with randomization. So to conclude, SBRT is a non-invasive nephron-sparing therapy. SBRT has excellent disease control and a reasonable impact on renal function. One could argue that SBRT could be considered the preferred modality of treatment for the presented case. I think that in an inoperable setting, that would definitely be a true statement. I think in an operable setting, it is, of course, debatable. And prospective randomized data of SBRT versus surgery are indicated.
Thank you, Dr. Sood. And last, Dr. Srinivas will tell us how systemic therapy may help us here.
So I'm going to pose the question is there a role for systemic therapy in a patient like this who has a cancer in a solitary kidney? So we heard that local therapies for patients with RCC would be a partial nephrectomy, ablation, and SBRT. But you can only preserve function if adequate nephrons are left behind. All of these ablative procedures, SBRT and partial nephrectomy, are good for tumors that are less than 3 centimeters. But for this patient with a mass as large as 7 centimeters, could there be a role for systemic therapy to shrink the tumor down to be able to then undergo ablative or partial nephrectomy subsequently? So I'm going to say a little bit about why I think we should consider additional therapy is the alternates would be dialysis, which clearly this patient has said he wouldn't want to. And then a renal transplant is something that you're looking at. We spoke a little bit about loss of renal function with any of these procedures. And again, you know, we've shown previously that there is a high response rate that we have with systemic therapy. But in a situation like this, I think you have to weigh in the risk versus benefits. Systemic therapy is not without side effects. And again, there's a lot of unknown. Really, the level of evidence or the data for this is even more lacking compared to patients with IVC thrombus. So dialysis was mentioned, you know, whether it's hemodialysis or peritoneal dialysis, the 5-year survival is less than 50%. And every year accrued on dialysis results in a 6% increase in death. So clearly dialysis is not optimum, and most patients don't want to undergo dialysis. Transplant is even harder. I think the wait time for patients who have cancer is now about 2 to 5 years of being cancer-free. They have to be on lifelong immune suppression, and they have to be on dialysis while they are awaiting a renal transplant. So outcomes after partial nephrectomy with positive margins have a negative impact on overall survival, on local recurrence-free survival, distant recurrence-free survival, as well as metastasis-free survival. So getting to an optimum size where partial nephrectomy can be done without positive margins, I think, is a goal. And then this was just a review looking at SBRT in RCC. And I think the thing here that struck me was, again, the size. None of these tumors were greater than 6 centimeters. So I'm not completely sure whether SBRT, what the data would be for large tumors. And then finally, I thought that this was a nice review looking at TKIs in patients with solitary kidney. This was looking from the Cleveland Clinic, looking at patients in the pre-TKI era versus in the TKI era, and they looked at different outcomes, including dialysis-free survival. So they had 23 patients who underwent neoadjuvant TKI, again, monotherapy. And of those patients, 91% were able to subsequently undergo a partial nephrectomy, compared to the patients in the pre-TKI era, where they had a dialysis-free survival of 60% compared to 91% when you were able to deliver systemic therapy. And overall, there was a decrease in tumor mass from 7.1 to 5.6 centimeters. There were decrease in renal scores. So all of these patients had a high renal score of 10 to 12, and they were able to show that with systemic therapy, you were able to decrease the renal scores. And tumor volumes decreased by almost 60%, making this amenable to partial nephrectomy. Again, I've shown this in my previous talk as well, that today with systemic therapy, we do have a high response in systemic therapy and a lack of progression that allows us to be able to deliver these treatments. Are there data about systemic therapy for these patients? You know, there's some about cabozantinib, again showing that giving cabozantinib for 2 months results in a 50% shrinkage in the tumor. Similarly, there is data with single-agent axitinib given for 8 weeks pre-op, again resulting in partial response, and also for single-agent nivolumab given for 3 doses resulting in stable disease. So some of the things that I think, again, are unknown in this is, if we were to opt with systemic therapy to try to get this patient to some form of ablative therapy or partial nephrectomy, what should the duration of therapy be? Should it be single agent, or should we have a combination with our therapy? And again, I think optimum imaging to really determine response is lacking. If you look at the time to response in all of our systemic therapies, in Checkmate 214, it was really 2.8 months, but you can see that there were some patients who needed up to 10 months of therapy in order to achieve a partial response. Similarly, in Checkmate 9-year, while the median was 2.8, there were some patients who needed up to a year or longer of therapy to achieve that kind of response. So I think the duration of response is somewhat unknown as to what is needed to achieve an optimum response to able to undergo ablative procedures. So I'd like to conclude again that these are clearly patients who need a tumor board or multidisciplinary approach. Systemic therapy does have a high chance of response, but I think for a patient with a solitary kidney, you have to take into consideration the side effects. And again, the duration of therapy could be pretty long in order to achieve that response. Endpoint in a patient like this should really be, how can we best preserve renal function to avoid dialysis, and ability to get this patient to a partial nephrectomy or ablation should be the goal. So I think I'll stop with that.
Great, so I'll thank the panelists again for doing a great job of laying out the data, or what data is there, and the arguments for these approaches. Once again, I'll open it to the floor. If anybody has questions, comments, please grab a microphone. You got there first.
If the patient said no to surgery due to the risk of dialysis, and has slowly growing tumor with no metastasis, when shall we start medical therapy? Wait till the patient metastasizes, or start earlier? What do you think?
That's a great question. I'll let Dr. Srinivas kind of ask that. Growing tumor, no metastatic disease or no visible metastatic disease, would you initiate systemic therapy or consider it?
That is a tough question, because I think you want to see what the goals for these patients are. If surgery is not an option and the patient is just, I would watch the patient till they develop metastatic disease. If the goal is not to get them to some form of a procedure that can render them disease-free.
Good morning.
Oh, sorry, Dr. Sood was going to chime in too. Sorry.
All right, we'll try another mic. I would argue that this is a situation where it's really important to understand the goals of care. Why does this patient not want to go to surgery? Is it because they want no treatment, or is it because they specifically want to avoid resection? Because this is an area where SBRT really offers a window for a treatment that is minimally invasive. It's not without any side effects, but oftentimes it's really important to really suss out what patients are trying to avoid and what they are seeking to accomplish, because I think it helps us open up other modalities that can help achieve those goals for them.
Sorry.
Thank you, first of all, for your thought-provoking talks this morning. I actually have a question about the first presentation, the thrombus, and it's sort of a general question, but is there a role at all for anticoagulation in managing IVC thrombi, whether it's, with the renal primary or even afterwards, if there's an IVC thrombus by itself?
Yeah, excellent question. I think that in the absence of a patient that is actively bleeding from the tumor, yes, you want to anticoagulate those patients to prevent any sloughing of clots and cause pulmonary emboli. So yes, as long as the patient doesn't have a bleeding tumor.
And I'll give the opposite perspective. So that you ask 10 surgeons, you'll get 55 of them will say, put them on anticoagulation, 5 won't. I think when you have an occlusive thrombus, there's definitely a risk of clot, and specifically pulmonary emboli or propagation of that. So in those cases, yes. In a patient who presents with a thrombus that is non-occlusive and no evidence of clot, I typically don't put them on anticoagulation. But after surgery, this is a major abdominal surgery, they're at risk, so those patients are now going on 30 days of anticoagulation in our practice. You, sir.
Yeah, I'm a radiation oncologist. Actually, I'm a part of the IROC group. So actually looking at the location of the tumor, actually, I think, one can potentially avoid a risk of, first, I think, before the treatment, based on the EGFR, and you can, ask me based on the radiation plan, how much kidney can be spared, and as long as you can, leave behind like 15, for the EGFR, probably the patient won't go into dialysis. And in this case, actually, because it's in the lower pole, when you do radiation, there's a spillage superiorly and inferiorly, but, for the inferior part, you spill into non-kidney tissues. You only spill into the kidney tissue in one direction. So I think in this case, it's highly feasible that the patient would still have adequate renal function after treatment.
Thank you.
I mean, just to add, I think that we talked about clinical trials between SABAR and the comparator group, and I think that just to put things out there, I mean, I think surgery is not the greatest comparator because it's going to be hard to accrue somebody that is surgical candidate to get radiation just because there's hard to follow those patients moving forward. We don't have good matrix of how these patients are going to progress. But I think an active surveillance cohort will be a great patient to actually use as a comparator group because we know that patients in active surveillance, even with T1B masses, it's not like they all 100% are going to have metastases. So I think that for those patients that are comorbid, that we struggle in finding options for, besides active surveillance or watchful waiting, I think that those are actually the greatest comparator arm to see they decrease secondary outcomes like bleeding or potentially progress the disease, just as you're looking, guys, to open trials.
And also, I think it would be nearly impossible because based on the AUA definition of progression, all the SABR-treated patients would have progression because there's always some contrast enhancement.
Yeah, I think this brings up multiple points. I'll first say thank you for your service to the field in terms of really kind of leading the charge of bringing, SABR into the treatment modalities and generating a lot of the data that many of us use, every day in clinic. I think you bring up a great point in terms of the clinical trials where we need real-world, pragmatic clinical trials. Sometimes the kind of old-school paradigm of, pick one, pick two things, compare them head-on. We need to really think about what's going to be feasible in clinic, what incorporates what patients are looking for, and where there is truly equipoise. And another great point was brought up about imaging modalities. If we use conventional imaging, then yes, absolutely. It's really hard to prove that radiation works. You get you go to surgery, the tumor is gone. Usually you give systemic therapy, it shrinks. And I field this question every single day from my patients where they say, it's still there. What do we do with that? How do we know that it's responded? And so I think a lot of the innovations that we're talking about, overall will help kind of bring this to the forefront and into reality.
Dr. Karam.
Good morning, and thank you all for your excellent presentations. Just a couple of quick comments. The first one is something we just touched upon, which is how do we define things? And we have a lot of patients and representatives here, so if somebody is being told, you can't have surgery or you shouldn't have surgery, it's always a good idea to get a second opinion if time allows to do that. So that's number one. Number two, I agree about doing thoughtful clinical trials. But it's very important how we define things. For example, there was one study that was shown that patients are supposedly non-operable, but there's a median follow-up of 4 years. So to me, why is somebody inoperable but can live at least 4 years? So that's, it's very important to define that. And also, how do we define local control, specifically in radiation trials? Apparently, we can't use contrast enhancement, so what do we do? Do we do biopsies? And that will bring me back to my fellowship days or residency days where we do biopsies for patients after radiation for prostate. It's positive, but we're being told it's not real, you can't believe it. So we have to better define how we are talking about local control, specifically in radiation trials, because we have to use something, either tissue or imaging, in order to be able to do these trials in a thoughtful manner. Thank you.
Great comment.
So one comment about a biopsy. Actually, the 3 trials utilize, biopsy after SABR to look at a response, but didn't correspond to the radiographic response. 2 trials from UH, Case Western, and 1 from UT Southwestern. A lot of those cells may be senescent cells, what you see under the microscope.
Thank you. So we've got a couple minutes left, and I'm going to ask one question that didn't come up in our debates. So Dr. Sood, do we lose anything after stereotactic radiation? How hard is our surgeries if we need to do surgery after radiation?
So this brings up a critical question of if something comes back, where does it come back? Is the issue that there was a problem with local control, or is the problem that there are metastases? Oftentimes the local control rates are really good if we're able to get adequate dose. The main challenge that we're oftentimes thinking about with a large tumor is what are the abutting structures? If we can get the dose in, we usually do really well. When I have scenarios where I need to undercover because there's bowel nearby or another critical structure, that's usually where we might struggle a little bit more. But in a setting where we're talking about development of metastases, then this question of, what does the surgery become worse? It's very much limited to a very small subset, and usually not the prevailing scenario that we're dealing with.
Andres, do you have any experience surgery after radiation?
No.
You have very limited experience. It hasn't been particularly impossible. It's also, I would say it's one of those operations where objectively you're not going to find any differences in blood loss, but it is not the same as doing a kidney that has not been operated on. Oh, Dr. Shook.
Phil, so we use this as a bridge to transplant. A lot of times they're transplant patients, they can't get a liver transplant and they won't want to use it. So we've done this a couple times. I'll just say the tumor always looks viable and healthy, and that kind of scares me adopting this as a standard of care, because in every patient we've operated on, they've a healthy looking viable tumor without necrosis, which you don't see with systemic therapy, where sometimes you see pathological complete response. Whether you claim it's senescence or not, that's to be debated.
Okay. Dr. Zhang?
Great debate and discussion. There's a current SWOG NRG trial, Samurai, looking at radiation to the primary, and there's some discussion about upper limits of how large a tumor would we all be comfortable radiating. So I'm curious if the panel have thoughts about how big of a primary is good for radiation.
I'll say that, for us, it's less so oftentimes the objective size and more so what the surrounding critical structures are. And the likelihood that you have critical structures abutting when you have a 7-centimeter tumor is much higher than when you have a 3-centimeter. And so it just becomes harder to get the dose in feasibly. I think oftentimes, while it's pragmatic to have a size cutoff on a trial, what's more important when we look at the protocols are the radiation dose planning constraints. And so having really high quality assurance for the plans to make sure that you know what the dose was to the tumor, what the coverage rates were, and that the normal tissue toxicity, that those dose constraints were strictly adhered to. And I think sometimes that prevents us from getting hung up on a number for size and really focusing on the quality of the radiation delivery.
Dr. Staller, last comment.
On the IROC data, I just want to remind you that the more fractions you deliver to the tumor, the less effective it gets. So we're good when we treat tumors up to 4 centimeters, and then we need to increase the fractions, and we are losing efficacy there. And that's something we got to keep in mind. The majority of the data of the IROC group are 25 grays in a single fraction with motion control correction there. So we got to keep that in mind. This tumor, to me, is a little bit too big for a primary tumor in a patient to really feel comfortable about it, and the majority of the patients in the IROC trial are from our center. So I'm not so sure about this. We got to be really cautious here that we select the right patients for that kind of really good therapy. We also recently published, and you kind of haven't seen that probably so far, a matched pair comparison versus surgery in elderly patients, and there's no outcome differences with smaller renal tumors, SBRT versus partials.
Thank you. So,
I think one last comment, and I think that sometimes it gets lost when we have surgeons here, but it's the fact that we're looking at masses less than 4 centimeters. Phil has done a tremendous amount of work here, is that active surveillance is a treatment. And I think that those patients can be safely followed in active surveillance management, and they don't need any therapy. So I think that active surveillance is still good treatment for patients with mass less than 4 centimeters that are stable in size. So I think that I wanted just to keep that in mind as we talk about these emergent strategies, that doing nothing sometimes could be the best thing for the patient.
So I'll just close the loop on the case, and then we'll transition to our next session. So that patient, I didn't tell you the whole story. So part of it was his wife had recently died, and he had started dating again. And so priority number 1 was no dialysis. Priority number 2 was no surgery because they wanted to go and see the world. And so he opted for stereotactic radiation. We're watching his mass. It has not changed in about a year now, and we're following him very closely. So I want to thank our panelists for their amazing job. I want to thank all of you for going up to the microphones. Do that all day long. We want to hear from you. So thank you very much. And we'll